I have the pleasure of introducing our speaker. Monica Roberts is Monica Roberts is an academic detailing pharmacist with the Healing Community Study. Prior to joining UK HCS, she practiced in community pharmacy and completed residency training with UK and Kroger Pharmacy. She is certified to initiate the dispensing of naloxone per protocol. And in addition to her PharmD from UK, she holds a BA in newspaper journalism and psychology from Syracuse University. Welcome, Dr. Roberts.
Thank you, John. So I do not have any relevant financial relationships to disclose. Like John said, I am an employee of the Healing Community Study. So my position is fully supported by the National Institutes of Health, but I do not speak for the National Institutes of Health or the HEAL Initiative. Everything here is my own. We'll click through some of these learning objectives. Mostly the goal here is to get you familiar with naloxone and kind of understand the ins and outs of overdose education and naloxone distribution. So we built in some polls here just so you don't have to listen to me talk on and on forever, and to get some thoughts and ideas going. So we'll start with the first one. Do you have naloxone? And if you're in category E, you're in the right place, so no worries. So I'll share the results. It looks like many of you are here, have some, and are ready to use it. That's awesome. I feel like every time I do this poll, that number goes up, which means we must be doing something right. Nobody's in this what's naloxone category, so I guess I can just speed through all this. You guys know everything already. So before we kind of get into the meat of naloxone, I just want to make a couple notes. The first one is about OEND, overdose education and naloxone distribution, and harm reduction, and how they kind of fit together. A lot of times these get conflated, and people think of naloxone as equivalent to harm reduction. But OEND is really part of a bigger harm reduction picture. And it also is a piece that stands on its own outside of the harm reduction world. So harm reduction includes all kinds of services for people who use drugs: syringe services, infectious disease screening, fentanyl testing, observed use, those kinds of services to help keep people safe and healthy. Naloxone is part of that, making sure that people who are using drugs, specifically illicit drugs, have naloxone and can be saved if they overdose. But naloxone is also for anyone who might be at risk of an opioid overdose. So this includes people who are not served by the other harm reduction services, people who are on opioids for chronic pain, people who are in recovery and might be susceptible to relapse. A whole host of patients need naloxone that we don't think of as being in that harm reduction patient population. So try to think of naloxone as something that's kind of for the whole gamut of opioid use. The other point I like to make before I sort of dive into the details is to talk about the nomenclature and the names we use for naloxone. So you all are probably familiar with Narcan, which is naloxone and is a brand name for naloxone. Narcan was originally approved in 1971, and it looked like this. It was an solution for injection. It came in vials or ampules like you see here, and it was mostly used in the hospital. So in the hospital for anesthesiologists and in the emergency department for overdoses. It was on the market for a long time. It eventually became generic. In the 90s, the generic version of Narcan started to be passed out by harm reduction programs to the public to help them save people who were overdosing outside of medical settings. So for a long time, naloxone and Narcan were exactly the same thing. As that bystander naloxone distribution started to pick up steam, the drug companies and the FDA said, oh, we need products specifically for that purpose, for bystanders. So the first one of those that came on the market was called Evzio. It looked like this, and it was an auto injector that you pulled the cap off and it told you how to administer it. You jabbed it in the person's leg and it automatically gave the dose. So this came out in 2014, and then hot on its heels, the people that made Narcan came out with Narcan nasal spray. This came out in 2015 and is a single-use nasal spray device. This was a lot cheaper than the auto-injector, so it rapidly became the drug of choice for bystander overdose rescue. As a result, in 2020, the Evzio people finally gave up trying to make any money off this super expensive product and took it off the market. If you still have Evzio sitting in a closet somewhere and it's not expired yet, it is still good to use. They're just not selling it anymore. So that is no longer available. So for a little while, we were back to just Narcan and Naloxone, same thing. In 2021, we got Cloxado, which again is a nasal spray. It looks just like Narcan nasal spray, but it's a higher dose. We'll talk more about the dosing in a little bit. And in 2022, we got Zimhigh, which is an injectable naloxone designed for bystander use. So this is not a fancy auto injector. It's just kind of a pre-filled syringe. But the important thing here is that all of these things are naloxone. The generic name for all of them is naloxone. So I will try to say naloxone throughout. Even I still slip sometimes and say Narcan because it's just in our vocabulary that way. But remember that any of these things are naloxone. To further complicate things, we have one other product that has recently come on the market, and it is called nalmefene. This is not naloxone, but it is in the same family as naloxone, and it works the same way. It originally was approved in 1995 and then pulled off the market in 2008, but it is back as a generic, re-released in 2022 by Purdue Pharma, who says they are distributing it for no profit. Can't imagine why Purdue Pharma would want to distribute that for no profit. But it is only for use in hospitals and emergency departments for the moment. We don't know if anybody's developing a bystander product that is nalmefene. But for now, because of some of the quirks of the way nalmefene works, it's only available in hospitals and emergency departments. So I'm not going to go deep into nalmefene today. Everything from here on out that we're going to talk about is naloxone, but I did just want to mention it in case it starts to pop up in the world, or you see it or somebody asks about it, you'll know, oh, it works the same as naloxone with a few differences, but it is not naloxone. We'll go through overdose epidemiology pretty quickly because I don't think it's a surprise to anybody here. The important thing about these graphs are what drugs are involved in drug overdoses right now in the United States. So we had more than 107,000 overdose deaths in the US in 2021. And you can see on this slide that the biggest chunk of these deaths is coming from synthetic opioids, primarily fentanyl and fentanyl analogs. This is not the fentanyl that we use in the hospital for pain management and sedation. It's not the fentanyl that we get in patches for outpatient use. This is primarily illicitly manufactured fentanyl, which comes in a powder form. You'll also notice there's an uptick in overdose deaths from a lot of other drugs like cocaine, methamphetamine, and benzodiazepines. And the important thing here is that these deaths that involve these drugs often also involve fentanyl. So we're seeing a lot of contamination in the drug supply. We're seeing a lot of polysubstance use. The reason this is important to naloxone is that we're going to talk about what an opioid overdose looks like. And anything that looks like an opioid overdose should be treated like an opioid overdose, even if you think the person was trying to take methamphetamine or cocaine. We're seeing even benzodiazepines and prescription opioids, things that are sold to look like tablets, actually containing fentanyl and causing overdoses. So, like I said, anything that looks like an opioid overdose should be treated like an opioid overdose. Here in Kentucky, we had 2,250 overdose deaths in 2021. Unfortunately, this picture really has not changed in the last 2 decades. Eastern Kentucky, the Appalachian counties have been hit very hard, Central Kentucky, Northern Kentucky, kind of the epicenter of all of this. Opioids were involved in 90% of overdose deaths in 2021. Fentanyl was in 73%. I mentioned the polysubstance issues. Methamphetamine was identified in 48% of drug overdoses in Kentucky. We always like to go through risk factors and prevention steps when we do overdose education and naloxone distribution, because the best naloxone is the naloxone you don't need to use. I think of risk factors for opioid overdose in two categories. The first one is the drugs that the person has taken. So drug exposures that increase the risk for opioid overdose include heroin and other illicit opioids, concurrent use of CNS depressants, benzodiazepines and alcohol are the big ones here, but anything that can be sedating adds risk when you're adding opioids in. High dose opioids, so here we're talking about over 100 morphine milligram equivalents. Methadone use for pain, this is just kind of a quirky pharmacology thing. And then opioid rotation, so this is true both for patients on prescription opioids and for people using illicit opioids. Anytime you switch from one opioid to another, the tolerance is different. So we have to be super careful about how we dose opioids when we're going from, say, oxycodone to fentanyl, or if somebody is used to using heroin and they're switching to fentanyl for whatever reason. That is a point at which we're at high risk for overdose. The other set of factors that increase risk are the situation of the patient themselves. So a history of substance use disorder, a recent previous overdose. Big one here is recent discharge from an abstinent environment. So people are at extremely high risk for overdose when they are released from jail, sometimes when they're discharged from the hospital, if their opioids have been changed while they were in the hospital, and even people exiting treatment programs, if they have been in abstinence-based treatment programs, the risk for relapse and overdose is high. This is because tolerance has reduced, and so less opioid is needed to cause an overdose. And then lastly, comorbidities and the person's general health status. So respiratory disease, renal dysfunction, hepatic dysfunction, even just feeling ill or being sick can put people at a higher risk for opioid overdose. When we talk about overdose prevention, we've again got kind of two categories. There's the folks on prescription opioids. These are recommendations for staying safe with prescription opioids, taking them as prescribed, knowing what they look like, storing them in a safe place so that nobody else is overdosing on the opioids that you've been prescribed. And again, using caution when you have medication or health status changes. For people using illicit drugs, the prevention steps are a little different. We want to be careful when we're using drugs from a new source, start slow, use less, space out doses, avoid using alone, make sure somebody knows where you are when you're using, stagger use in a group. And then again, try to keep yourself as healthy as possible so that your body can deal with the opioids. By the way, if anybody has any questions or comments, feel free to throw them in the chat or just come off mute and interrupt me. I don't mind stopping for a little bit. So let's talk about opioids and naloxone and how they work. Opioids work in our brain at multiple receptors. The main one that we're worried about is the mu opioid receptor. When the opioid sits down in that receptor, it turns the receptor on and causes a cascade of effects that give us the effects that we expect from opioids. So these include pain relief, potentially euphoria, respiratory depression, sleepiness, dizziness, confusion, and then our sort of side effects, constipation, nausea, itching, urinary retention, all these expected effects of opioids. If somebody takes a high dose of opioids, we say that they are over-medicated. This is going to be that intoxication picture. They're sleepy, they're hard to keep awake, confused. They're going to have a slowed respiratory rate and a slowed heart rate. This might be hard to detect if they're not in a hospital monitoring environment. but this would be present. And then those pinpoint pupils, so the pupils starting to constrict. This state of opioid overmedication is not yet an overdose, but it could become an overdose. This could be a step on the journey to overdose, or it could be on the way back out. The person might recover from this stage with no intervention. When we reach opioid overdose, the two main things we see are non-responsiveness and respiratory depression. So the person is not going to respond to intense stimuli, shaking, yelling, and then or a sternal rub. So if you take your knuckles and rub them down the breastbone, it's fairly painful. Somebody can wake up to that stimulus, they will. They'll probably tell you to stop doing what you're doing. That's going to be the first thing that you do to check and see if the person can respond. You'll see infrequent or shallow respirations. It might look like the person has stopped breathing altogether. You'll start to see signs of hypoxia, so blue, gray skin, lips, and fingernails, those signs that oxygen is not getting to their extremities. Again, the blood pressure is going to drop, the heart rate's going to slow down. If this continues and progresses, eventually the person will be in a coma, and then you'll have death if it's not reversed. I've added this slide to this presentation because we have some situations that have been popping up in the news lately that are not overdoses, but there's kind of two flavors of this story that shows up over and over and over again. And I think it's important to talk about this and kind of help people understand what's going on here. The first sort of theme story is up here on the right. This is actually from WKYT here in Lexington. You probably saw it on Facebook over the summer. There's a woman from Lexington traveling through Tennessee. She stopped at McDonald's. She said she picked up a dollar bill off the ground, and then they got back on the road and she started to feel funny. She went to the hospital and she insists that she had been exposed to fentanyl and had a fentanyl overdose from this dollar bill that was on the ground. And we've seen several of these stories pop up about people picking up something that had fentanyl powder on it and experiencing an overdose. The other kind of brand of this story tends to come from our law enforcement officers, where they are exposed to something in the course of searching a suspect or a car, and they believe that they are exposed to fentanyl in that way. So in this bottom story, which is from Michigan, two sheriff's deputies were searching a backpack and they said an aerosol powder came up in the air. They immediately felt nauseous and dizzy. And one of the deputies said his heart rate was 220 beats per minute. So they self-administered naloxone to each other and went to the hospital. And you can see the quote here about how without naloxone, we might have had a bad situation. I obviously have not examined any of these people in these stories, but I feel almost 100% confident saying that neither of these situations was an opioid overdose for a couple different reasons. The first is that fentanyl powder getting into your bloodstream through the skin is incredibly unlikely. Skin is an amazing barrier. It keeps all kinds of things out of your body. And fentanyl powder is not just going to get absorbed through your skin in a quantity sufficient to cause an overdose. We have fentanyl patches that work through the skin. They took years to develop, and that liquid that the fentanyl is in is highly engineered to get through the skin barrier and into the bloodstream. So the idea that you could put enough powder on a dollar bill to absorb through the skin and have an overdose is just too far-fetched to believe. The other element here is that opioid overdoses have predictable symptoms. We just talked about it. We know what opioids do. We know what it looks like when somebody is having an opioid overdose. Someone who can self-administer naloxone or administer naloxone to somebody else is not having an opioid overdose, even if they were exposed to something. The naloxone is not really helping them in that situation. So I say this not to make fun of people who are worried about this, but to say there's a lot of anxiety in the world right now about fentanyl. And I think we can take the temperature down. And I'd like to deputize you all into my army of Mythbusters to say to people, this is not something you need to worry about. If you're not using illicit drugs, if you're not taking prescription opioids, your risk of overdose from opioids is almost non-existent. So please push back on people that share these stories, because this is just not a risk. And the things that we should be worried about, instead of warning people not to pick up money or worrying about rainbow fentanyl in your kids' Halloween candy, should be educating people about the ways people are being exposed to fentanyl. Talk to the teenagers about not taking pills from other people that they don't know what's in them. Only take what's prescribed to you. Talk to people who are using drugs about testing their drugs for fentanyl. Those are the people that are at risk, not the folks picking up a dollar bill off the street. On the flip side, all these stories do reiterate my point that I will make over and over today, that naloxone is safe, right? These sheriff's deputies gave it to themselves and they were fine. So we don't have to worry about giving naloxone to somebody who maybe isn't experiencing an overdose, because it's not going to give them a ton of harm. It is, if they're not experiencing an overdose, and they're definitely not experiencing an overdose, though, it's kind of a waste. So how does naloxone work? I apologize to anybody if this brings back nightmares of chemistry class, or if they can't stand to look at these chemical structures, but I think this is cool. So oxycodone, the opioid, is on the left. Naloxone, which we call an opioid antagonist, is on the right. And what naloxone does is it fits in the receptor just like oxycodone does, but it's just different enough that it doesn't turn the receptor on. So we call this a pure opioid antagonist. You can see in the picture, the receptors prefer naloxone to the opioids. So the receptor is going to grab on to the naloxone, and the naloxone is going to block the opioid from connecting to that receptor and turning it on. For people that do not have opioids typically in their receptors, there is no effect of naloxone, even up to doses of 1 milligram per kilogram, which is a massive dose, like 20 times the dose that we would ordinarily give of naloxone. In patients that are used to having those opioid receptors turned on because they've been on opioids for a long time and are physically dependent on opioids, it will precipitate acute withdrawal symptoms. So the naloxone comes in, moves the opioid off the receptor, and all of a sudden you're in withdrawal fairly quickly, and potentially fairly severely. So acute withdrawal can range from mild symptoms, agitation, goosebumps, to kind of moderate, very unpleasant symptoms, vomiting, headache, all the way up to, in rare cases, life-threatening symptoms like cardiac instability and pulmonary edema. And we know to some extent this depends on the dose of naloxone that we give. It also depends on the level of tolerance and the opioids that the person has in their system at the time. But for somebody that is not opioid dependent, naloxone is not going to have any effect. We have several naloxone products on the market, like I mentioned earlier when we talked about their names. These ones I consider kind of our traditional naloxone products. This is the naloxone solution for injection. It can be given either IM or IV. It can also be given in nasally if we use what we call an improvised nasal device. So this is where you draw up the naloxone out of the syringe and you screw on that little knob and it turns it into a nasal spray, so that when you press the syringe, it sprays out into the nose. The doses we use with these are 0.4 milligrams, usually intramuscularly, or 2 milligrams in 2 milliliters in the nose. And so usually we would do 1 mil in one nostril and another mil in the other nostril. You can imagine that was a lot of liquid back before the other products came out and we were doing this regularly. It was hard to get all that into the nose. Luckily, we have these products, which are approved for bystander use. So the first one is Narcan. It is 4 milligrams in 0.1 milliliters, so much easier to get into the nose and absorb in that nasal cavity. Narcan has now been out long enough that we have generic versions of Narcan in that 4 milligram dose. We also now have Cloxato, which I mentioned earlier. Same kind of device, same nasal absorption. This one is 8 milligrams in 0.1 mils, so double the dose of Narcan. And then we have Zimhigh, which is that IM injection. And this dose is 5 milligrams in half a mil. And this 5 milligrams is actually the highest dose that we have, because more is going to get absorbed when you do it IM compared to if you give it in the nose. So Zimhigh is 5 milligrams, where we used to use 0.4 milligrams when we were drawing it up out of the vial. So that's a big change. So we've got all these doses. You might be thinking, what is the right dose for naloxone? And that's a good question that I don't have a great answer to. I mentioned earlier that withdrawal is going to depend on the opioids present and on the naloxone dose. Effectiveness and duration of action are also going to be affected by the dose that we give. We do know naloxone has historically been highly, highly effective. So studies range from 80 to 100% of naloxone rescues are successful. And that 80% studies often include unobserved overdoses. So that includes people that perhaps had passed away before the naloxone had even been given. Most of those studies were done in the pre-fentanyl era, but at the time that the studies were done, 0.4 milligrams, 2 milligrams was successfully rescuing people most of the time. We also know that EMS and bystanders are currently administering more repeat doses, but we don't know exactly what that looks like or what doses they're repeating. We don't have all the details. We just know that people are giving more naloxone. And most of the guidelines that we have recommend using the lowest effective dose to minimize withdrawal. So this is the idea that you would titrate the dose. You would start with a lower dose and give more and more and more and more until the person starts breathing again, as opposed to giving one big whopping dose and potentially causing the person to go into withdrawal. There's a lot of debate right now about whether this should be split apart and say, do that in the hospital where you can titrate and you've got all the other support structures in place, but don't do that if you're a bystander, right? There's kind of this debate about whether bystanders can or should try to titrate to avoid withdrawal. The indication on all of our naloxone products is emergency treatment of known or suspected opioid overdose and intended for immediate administration in settings where opioids may be present. So I always put this up to point out that you don't have to know for 100% certainty that the person is having an opioid overdose to give it. Even the FDA has said this is to use if you suspect opioid overdose or opioids might be present. When drugs are approved, they're always approved with contraindications and precautions. Contraindications are instances where you should not give the drug no matter what. Precautions are instances where you have to kind of weigh the risks and benefits. The only contraindication for naloxone is hypersensitivity, or essentially allergy to naloxone or one of its components. And there is even some argument that because naloxone is saving a life, even if you knew somebody was allergic to naloxone, you should give it and then treat the allergy after the person has recovered from the overdose. It is not all that important to remember that, because there is no documented instance of somebody actually being allergic to naloxone. The precautions include a risk of incomplete reversal. So this can happen if you've got opioids like buprenorphine that work a little bit different. And it can also happen if the person has overdosed on multiple substances. So naloxone is going to reverse the effects of the opioid, but if the person has alcohol, benzodiazepines on board, you're still going to have the sedation and all of the symptoms of those drugs that the person has taken. The effect of naloxone is limited in duration. So this is an important one. Naloxone works usually for around 2 hours. And a lot of our opioids stay in the system longer than 2 hours. So remember how naloxone works. It comes in and it bumps the opioid off the receptor and it sits on the receptor. That opioid is still potentially in the bloodstream and still in the body. So if naloxone pops off the receptor and moves on and goes out of the body, it stops working, that opioid can come back and sit back down on that receptor. So if the person has overdosed on something that stays in the body longer than naloxone, they could potentially slip back into an overdose after the naloxone has worn off. This is one of the reasons why it's really important to call 911, get extra help, continue to monitor the patient, even after they've recovered from that initial overdose. The last precaution is precipitation of severe acute withdrawal syndrome. So we've talked about that. The naloxone is going to immediately put somebody into withdrawal if you knock all of those opioids out of their receptors. For pregnant and lactating people, naloxone is very safe. The big concern in pregnancy is that withdrawal syndrome. So if mom is in withdrawal and potentially the fetus is in withdrawal, there could be blood pressure changes and changes in oxygen that would put the fetus in distress. So obviously in a life-threatening situation, the fetus's best chance is for mom to live. So we want to give the naloxone, but then we need to really make sure that they're monitored for those signs of withdrawal. For a lactating mother, almost no concerns at all. Even if naloxone gets into the milk, it does not get absorbed from the stomach. So no concerns with lactation. Again, use naloxone in a life-threatening situation. It's not a hard decision. If somebody is having an opioid overdose, give the naloxone. All that to say, naloxone can save a life, but it is not a substitute for calling for emergency medical care. So I've kind of gone through all of the things that could happen after we give naloxone, and we want to make sure that somebody is there to help move that person into the next step of the rescue, right? Naloxone is the first step, and it could be the difference between life and death, but it's not the only step in saving that person's life. So we'll jump to another poll. Who do you think should have naloxone? And I don't know if it'll let you in the poll, but this should be choose all that apply. All right, everybody is saying all of the above, F, people who are willing to use it. Right. Okay, I think you all are on the right path here. So who needs naloxone? In 2016, the CDC guidelines for using opioids to manage chronic pain came out, and their recommendation was prescribe naloxone to high-risk populations. So you can see here, folks that were on high opioid doses. This is all of our people at risk, right? So this is kind of one recommendation the CDC presents. In 2018, the Surgeon General at the time, Jerome Adams, issued an advisory on naloxone and opioid overdose. And you can read it here. He talks about for patients currently taking high doses of opioids, individuals misusing prescription opioids, individuals using illicit opioids, and so on. Knowing how to use naloxone and keeping it within reach can save a life. When he issued this advisory, he did kind of that press tour that they always do to talk about things. And we're going to listen to a clip of what he said on NPR about who should have naloxone.
Over half of the overdoses that are occurring in homes. And so we want everyone to be armed to respond. We should think of it like an EpiPen or like doing CPR on someone.
So you can hear, he said, we want to think of it like an EpiPen or doing CPR. He kind of put it in that like first aid category. So I think if you asked Jerome Adams, he would say F, all of the above. Everybody should have it. In 2020, the FDA put out a drug safety communication to talk about who should have naloxone. And they said that prescribers should routinely discuss naloxone with all patients when prescribing or renewing an opioid analgesic or medication for opioid use disorder. And then they kind of gave examples of who you should consider prescribing naloxone to. They also encouraged healthcare providers to educate patients and caregivers on how to respond to an overdose. So a variety of recommendations, but I think the take-home message is a whole population of people should have it. So why do we want so many people to have naloxone? Because we know that it works. It works to save lives. We have studies that show administration during an overdose by bystanders, not healthcare professionals, increases the odds of survival compared with no naloxone administration. We also know that communities that have more naloxone in the community have lower rates of opioid overdose deaths. So this graph is from a nice little study in Massachusetts when they first got the ability to have overdose education and naloxone distribution programs in the state. They looked at communities that had no enrollment and what happened to their, or no program and what happened to their opioid overdose rates. And then they looked at communities that had a program but had low enrollment and communities that had a program and had high enrollment. And you can see that the high enrollment dropped overdose deaths more than the communities that didn't have a program at all. I've mentioned a couple times people that are in recovery, and this was an interesting little study about patients that had been started on buprenorphine. They looked at almost 1 million unique patients filling a buprenorphine prescription. And the reason they did this is because people that are on medications for opioid use disorder should have naloxone. Their risk of overdose is dramatically lowered compared to people that are actively using illicit substances. However, they are still considered at risk of an overdose, both because they have the potential to relapse and also because the potential to relapse goes up when they stop taking buprenorphine. So we know that this can happen. We have access issues at times. We have people who decide that they're ready to stop. We have prescribers that taper it because they think they should. So folks that are on buprenorphine should have naloxone on hand. Unfortunately, the study found that a naloxone prescription was filled during only 4.5% of treatment episodes. So there's a few limitations here. We don't know if the prescription was offered but not filled. But we do know that only at the end of the day, only 4.5% of people filled that prescription. Filling the prescription was more likely if the prescriber was an addiction specialist and more likely if they were a physician assistant or nurse practitioner compared to a physician. And then the prescription was less likely if the buprenorphine prescriber was an emergency department physician, pain specialist, or psychiatrist. So those are folks that would be prescribing buprenorphine that we really want to encourage to prescribe naloxone along with those buprenorphine prescriptions. The last bullet point we'll kind of come back to, there was a higher rate of filling that prescription for people on Medicaid and Medicare compared to commercial insurance, coupons, or discount cards. So this gets to our barriers in terms of price with naloxone. So another poll, if you have naloxone, how did you get it? And if you are thinking you're going to go get some, how would you go get it? So our community overdose awareness events are doing a great job. I'll have to give a shout out to our prevention specialists who are doing these all over our healing community study counties. It looks like that's a big source of naloxone for people, the local health department, and then a handful of other options. So we'll talk about naloxone access. So I group the way you can get naloxone into kind of 3 categories. The first is the traditional way by prescription. It is a non-controlled prescription medication. So any prescriber who can write a prescription can write a naloxone prescription. You don't have to have a DEA registration. You don't have to be a certain level of prescriber. You can write a naloxone prescription. You can also write a naloxone prescription as a standing order for a clinic or a health system. This is basically a document that says anybody that meets these criteria can have a dose of naloxone. We're seeing an increasing amount of co-prescribing with an opioid prescription. So this is the idea, again, kind of like with the buprenorphine, any patient that meets certain criteria with their medications also gets naloxone. If you are a prescriber and you're going to start prescribing naloxone, I have this sample prescription on the screen here. This is how I would recommend writing the prescription as a pharmacist. The two big things are to provide full directions. Do not write use as directed. Keep in mind that the person administering the naloxone is very likely going to be somebody other than the person to whom you've given the prescription. So they need to know what it's for and how to use it. And then plan extra time or designate somebody on your staff to provide education to patients and their caregivers to make sure that they know what they're doing with the naloxone. The pharmacy is going to help with this, but in those instances where, you know, somebody picks up their prescriptions and says, no, I don't have any questions, see you later at the pharmacy, they could potentially get home and have never had anybody talk to them about this prescription that they have. So you want to make sure that people know what it's for and how to use it. I have tips here for talking about naloxone. I'm not going to spend a lot of time on this. One point I like to make is that a lot of prescribers feel a little uncomfortable bringing this up with their patients, particularly their patients that have chronic pain, because of issues around stigma and sort of this thought that people who are taking their prescriptions as directed are not at risk for overdose. So we like to emphasize that overdose is an adverse effect of a drug, and we would do anything we could on any drug to try to prevent and recognize adverse effects. So I always say use an analogy to other common safety measures. I use a fire extinguisher. I don't intend to set my kitchen on fire. I don't try to set my kitchen on fire when I cook, but I do cook in my kitchen. So I keep a fire extinguisher on hand in case something catches fire. The other point I like to make for prescribers is if you are speaking to somebody that is on prescription opioids, be cautious about using the word overdose. We have studies that show people on prescription opioids don't think of overdose as something that will happen to them. So they will connect more with the risk if you say breathing emergency or adverse reaction or bad reaction to the drugs that they're on. Another way in Kentucky that you can get naloxone is directly at your pharmacy without a patient-specific prescription. So here in Kentucky, if the pharmacist is certified, they can initiate the dispensing of naloxone under what's called a prescriber-approved protocol. So this is where a physician and the pharmacist enter into an agreement where the physician says, anybody that meets these criteria, you can dispense a prescription in my name to that person for naloxone. A note here, the pharmacist is required to train a person who gets naloxone in this way. So even if this is the 700th dose of naloxone that you've purchased at the pharmacy, they are still going to have to sit down with you and tell you what it is and how to use it. So it does take a little bit of time when you go to the pharmacy. It's not like you can just walk in and pick it up and pay for it. If you're looking for a pharmacy that has a protocol in place, the Office of Drug Control Policy has a map on their website where you can enter your city or county and find pharmacies that have a protocol. It's important to remember that these pharmacies might have a protocol, but they might not have naloxone in stock, or they might not have the naloxone product that you want in stock. It's also important to note that these protocols are not used every day in a lot of pharmacies. So particularly in the chain pharmacies, you might run into a pharmacist who's like, I don't really know how to do this. It might take them a little while to figure out the process to get it right. But I encourage you all to go to your pharmacies and make your pharmacists learn how to do it. The third way that you can get naloxone, which it sounds like is the way a lot of you all have gotten your naloxone, is through community OEND programs. So these are usually based on a standing order, and they're also focused on either a specific community or a specific high-risk population. So we see these at health departments and syringe services programs. There are local harm reduction organizations that do this. We often see pop-ups at community events with things like the Healing Community Study or another harm reduction organization. And then we're also seeing increasing OEND programs in criminal justice settings, jails and probation and parole, those types of places. If you're in a healing community study county, we are collecting community OE&D programs, and you can find some of them on our website. I mentioned earlier a barrier to naloxone is the price of it. This is actually better news than I usually share on this slide. The cash price at the pharmacy is coming down. We called a couple back in September, and it ranged from $50 to like $120, $130 for a cash pay prescription at the pharmacy. The public interest price, which is the price that the manufacturers sell it to health departments or us at the Healing Community Study or EMS departments, for Narcan is currently $47.50. This was $75 for years and years and years. And then Kloxxado and Zimhai came out and set their public interest price at $60. And all of a sudden Narcan's came down to $47.50. So that is good news. That is saving everybody some money. If you have insurance, Kentucky Medicaid covers Narcan and Kloxxado at no cost at point of sale for the patient. Medicare and private insurers depend on the plan. So I pulled Express Scripts Medicare formulary. They put Kloxxado and Narcan both on tier 2, and they made it a mail order drug. So they cover it, but there's kind of a higher copay, and you have to get it through their mail order pharmacy. Kloxxado, which is trying to elbow its way into the market, has a savings card that will reduce the cost of Kloxxado specifically. Health departments and harm reduction programs obviously usually give this away for free. So if you had a patient or if you are a patient who can't afford it at the pharmacy, those are options. Healing Community Study gives away thousands of doses for free. So if you can find a Healing Community Study program in your county, you can get a dose that way. And then the most exciting thing that we have to share is the Kentucky Opioid Response Effort. So this is a SAMHSA-funded state program that has a whole range of opioid response programs. It has been around for years. Just this year, they started the Kentucky Naloxone copay program. So they have always had naloxone access efforts in a whole variety of formats. But this one, for me as a pharmacist, is pretty cool to see coming up. And I think this will really help things get cheaper and easier for everybody. So this works just like those drug manufacturer copay programs that you've probably seen for brand name drugs, except it covers all naloxone products. It's not specific to one brand name drug. It is funded through the core funds, and it reduces the out-of-pocket cost by $60 for any naloxone product. It can be used on the cash price. It can be used on a copay. The only folks that can't use it are people that have Medicare or TRICARE or other federally funded insurance, because it is illegal to use these types of discount programs with your federally funded prescription insurance. But this is the card. This is the ID number. There is only one number. Patients don't have to register. This is run through McKesson's loyalty program, which is the same program they use for the brand name drugs. So the pharmacists should be familiar with how to do it. If you have patients or people that want to get naloxone at the pharmacy and they have a copay on it, please share the information with them that this exists. It's run, the Kentucky Pharmacists Association partners with CORE to make this happen. So they have more details on their website about it. At this point, you're probably thinking, why is this drug just not over the counter already? I have said every time I've given this presentation in the last 3 years to every audience, I think it's coming soon. So I'm going to stop saying that because it's not here yet. All 50 states allow pharmacists to prescribe naloxone or dispense it by standing order in some way. The FDA has said, please, 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 somebody apply for an OTC naloxone product. And the drug manufacturers just have not done it. They have not. There's a couple that say they're working on it, but aren't there yet. The FDA even went so far as to develop a model drug facts label. So ordinarily when a drug goes OTC, the company that wants to sell it over the counter has to do a study to show that the drug label is usable by the general population. The FDA went ahead and did this study for everyone. And they said, if you just use this label for naloxone, you don't have to do that study and submit it with your application. So they are pushing to try to get manufacturers to do this, and nobody has done it yet. So the next poll, what is the minimum level of training needed for bystander overdose response? And I can tell that you all have naloxone and have done this training, because most of you said brief training similar to new medication counseling, which I think is what most people are doing these days. I will talk briefly about overdose education. Some people said that they didn't think any training was necessary at all, and there's a good argument for that. I tend to fall in the brief training category being needed, in part because of this study that was done in 2017. They did this at the New York State Fair. They just had people who had never been trained in naloxone use before come in. They had a mannequin. They said that mannequin is having an opioid overdose. Here's a product, go save their life. And they let people just do whatever they thought they were supposed to do. They gave them either the nasal spray, an intramuscular injection. This was a vial and a syringe where you had to draw it up and inject it. And then that improvised nasal atomizer where you had to draw it up and attach the nozzle to it to give it. And then they just watched them and they followed them until they either successfully administered the dose or they committed a critical error. So something that meant that they were not going to be able to successfully administer the dose. You can see here that the nasal spray, 2/3 of people did it right, but 1/3 of people still committed a critical error in using that nasal spray. So it's not rocket science, but some people still didn't get it right. My guess would be a lot of people sprayed it before it was in their nose, and we'll talk about that in a minute. The nasal spray was the one that people used successfully the quickest and perceived as the easiest. About 50% of people got the intramuscular injection right, and then almost no one did the improvised nasal atomizer right. So I'm glad that that has kind of gone by the wayside as an option for bystander naloxone. On the flip side, there's this study that a lot of people point to that said that trained versus untrained rescuers in a study of substance using participants who reported having rescued somebody with naloxone saw no differences in doing the right steps or seeking help or successfully administering naloxone. This study is interesting, but it's a little misleading because the untrained people were just people who hadn't been trained by the program that they did the study in. They didn't have any evidence that the people had not ever been trained. They also did this in substance using participants who we would expect to be a little more familiar with naloxone than people at the state fair who they didn't screen at all for any. They just said, have you ever used naloxone before? Have you ever been trained with naloxone before? So two sides of the same coin. I kind of fall on the side of we should at least explain to people what it is and what to look for and how to use it before we send them out into the world with it. This is a list of recommended education for somebody receiving naloxone. Obviously, you don't have to spend 20 minutes on each of these 7 things. Some of these 7 things you can skip entirely if you're training somebody who is familiar with naloxone. But this is kind of the list I keep in my head when I'm doing naloxone trainings to say, I want to make sure that the person who leaves has some sense of each of these 7 things. We've already talked about the first 3, and we've talked about information on naloxone as well. So now we'll just kind of jump 2 steps in responding to an overdose. I mentioned earlier that you're going to check for responsiveness with that sternal rub. If the person is over-medicated or intoxicated, you just want to stimulate them and observe them. There's no need for naloxone at that time, but you want to make sure that it doesn't turn into an overdose. If the person is non-responsive, first thing to do is call 911. I tell everybody I train, if you only remember 2 things, remember to call 911 and remember where you keep the naloxone. Because if you have those 2 things, the 911 operator can help you with everything else. Administer the naloxone. We'll talk about the 2 ways to do that in a minute. Initiate rescue breathing if you know how, if you are CPR trained, or if the EMS instructs you on how to do that. If you're CPR trained, rescue breathing for opioid overdose is the same kind of breathing. You just give 2 breaths to start and then 1 breath every 5 seconds. You want to wait 2 to 3 minutes between doses of naloxone. So give the naloxone, start the rescue breathing, wait 2 to 3 minutes. 2 to 3 minutes is super fast in the realm of drugs working. But it is very slow when you're in an emergency situation and you think somebody is dying. So it can be hard to wait 2 to 3 minutes, but you have to give the naloxone time to work. You're going to look for breathing to resume. We're not expecting the person to sit bolt upright and be totally okay, or even sit bolt upright and be vomiting and in withdrawal. We're expecting the person to breathe normally. That's the thing that's going to keep them alive. So that's what you're working towards. You don't have to keep giving naloxone if the person is breathing. Stay with that person until help arrives. If they start breathing but aren't awake, or if you need to leave for any reason, you want to leave the person in the recovery position. This is on their left side with their hand under their head and their knees bent to keep them from falling forward onto their stomach. This helps them avoid aspirating if they vomit. It also helps kind of keep them in a safe position. If they wake up and they feel agitated, they are not going to hurt themselves or somebody. If you have nasal naloxone, again, this is super easy to do. You open, it comes in a little clamshell. You open up the clamshell, take the dose out. Don't test the dose. Don't spray the dose until it's in the person's nose. Place the nozzle in the nose until your fingers touch the bottoms of the nostril. Press that plunger. It'll spray the dose into the nose. If you need to use a second dose, you can do it in the opposite nostril. If you forget which nostril you used, it is not that important. That's it for administering nasal naloxone. If you have that Zimhigh injection, it looks like this. It has a little cap on the end of the needle. You pull the cap off, jab it into the thigh. It can go through clothes if you need to. Push the plunger, hold it for 2 or 3 seconds, just long enough to make sure that the dose is administered. Pull the needle out, and it has a safety device that I think is a little tricky to use. It's 2 little knobs on the end of the device that you just slide over the needle. That'll cover up the needle so that you don't accidentally jab anybody else with it. You can then put it back in the case and find a sharps container, or bring it to the hospital or somewhere, or give it to EMS. If you have naloxone, the recommendation is to store it in the original package and keep it at room temperature. The packaging is kind of excessive, so it can be hard to find a place to stick it that you'll have it on you. I say you can take it out, but take it out of the box, but leave it in the clamshells if you have the nasal naloxone. Don't open them up to where you might accidentally push the plunger. As far as room temperature goes, that is best. We don't want it to be frozen when we need it. So if you leave it in your car in winter and it freezes, you're in trouble. We do know that it can survive temperature fluctuations temporarily, but generally we don't want to keep it at 100 degrees or keep it at a super cold temperature for long periods of time. If stored properly, naloxone is effective at least until the expiration date on the packaging. Narcan keeps extending out their expiration dates. They keep doing studies to show that it's still good, still good, still good. So I think you get about 3 years now on a dose of naloxone when you get it. The newer ones, it seems like, are a little bit shorter. I've seen them around 1 year to 2 years. If all you have is expired naloxone, go ahead and use it. We're getting more and more studies that show that even 20-year-old naloxone is still effective. We would expect it to degrade over time. So it potentially would not be as effective, especially if it hasn't been stored perfectly the whole time. But go ahead and use your expired naloxone. It's not going to hurt somebody. It just might not work as well. If you're training people in using naloxone, don't reinvent the wheel. There are all kinds of organizations that have brochures and videos and helpful tools to help you train folks. These are just a few of the examples, but all you have to do is Google. You'll find great stuff. The last thing I like to talk about are legal issues around naloxone. We get a lot of questions about liability and safety and prescribing. So we'll dive into that in a little bit, and then I promise we'll be done. KRS 217186 is the main law here in Kentucky related to naloxone. If you've never looked this up, it's only about 1.5 pages long, and it's worth reading. It's pretty straightforward, and it really helps to drive home the point that the Kentucky legislature sees naloxone as very different from other prescription drugs. They have clearly said, this is a product that we need people to have. This is something that we support using broadly in our state. The one thing that KRS 217186 does is allow a third party to receive, carry, and administer naloxone. So naloxone is weird in that it's a drug that you don't necessarily take yourself, right? We don't prescribe blood pressure medicine to somebody so that they can give it to another person. But that is what we do for naloxone. So this kind of clears up that issue, that you don't have to use it for the name on the package. It also says a person or agency, including a peace officer, jailer, firefighter, paramedic, emergency medical technician, there's a couple other people listed here, can receive a prescription, possess naloxone, administer naloxone to somebody suffering from an apparent overdose, and even provide, as part of a harm reduction program, an opioid antagonist to persons who have been trained on the mechanism and circumstances. So this is saying that a pharmacy could dispense 24 doses of naloxone to an agency that runs a training program. And as long as that agency trains the people that they are handing the naloxone to, they can provide the naloxone to somebody else. So they can give it to another person as long as those people have been trained on how to use it. 217186 also provides protection for healthcare providers. So it says anyone who, acting in good faith, prescribes or dispenses naloxone to a person or agency to somebody who is capable of administering the drug. So again, they're saying you got to train people, but as long as you train people, you shall not be, as a result of your acts or omissions, be subject to disciplinary or other adverse action. It later goes on to cover people who are administering and providing naloxone, to say that they are immune from criminal and civil liability for the administration. So again, they're very clearly saying, we want people to have naloxone. We recognize that it's safe. We don't need as many safeguards in place for this drug. And we want people to be protected, even if something goes wrong, as long as that thing that goes wrong is not the result of negligence or misconduct. Then there is no liability to be had. So again, I encourage you to read this. I am not a legal person. I am a pharmacist, and I feel like I understand it fairly well. So if you have any liability concerns, read through this statute. The last statute that I like to mention is KRS 218A-133. This is what's commonly called the Good Samaritan Law in Kentucky. And this is designed to protect people from prosecution for possession if they call to get help for an overdose. So the idea here is that people are together using illicit drugs, somebody overdoses, the other people can call the 911. If the police come, they're not going to arrest people for possession as a result of that call to get help. Now, it's important to understand the details here. The protection is for prosecution for possession of a controlled substance or drug paraphernalia. It's also protection from prosecution. So police should not arrest somebody who can't be prosecuted, but sometimes they do. It also requires that the person remains with the individual, and that the evidence is obtained as a result of needing help for that overdose. So there's a lot of caveats here, right? It's not a get out of jail free card for calling, for the police showing up and saying, well, that person's overdosing, so you can't arrest me for anything. A lot of people feel like this law is not sufficient to protect people. On the flip side, a lot of people think that we shouldn't have a Good Samaritan law at all. But if you're educating people on this law, it's important that they understand kind of the ins and outs of it. So this statute is even shorter than the naloxone statute. So if you're gonna do any education on it, I would encourage you to read it and make sure you kind of understand those details.